Good afternoon, everybody, and I'd like to begin by thanking Anne-Louise and Sandy for the opportunity to speak today, and my colleagues at Toronto General and Princess Margaret. I never had the opportunity to meet your mum, but it seems from the efforts you're going to in terms of increasing awareness and the symposium here today, I think speak very elegantly of someone who must have been a very formidable lady. And I'm sure she's extremely proud of what you're doing, as you both should be. This is a terrific initiative. To begin with, a few disclaimers. Pancreas cancer is a big thing. There are lots of different types of disease, and there's a lot of noise. To avoid making a talk on surgery, adjuvant and neoadjuvant therapies unmanageably nebulous, I'm going to take a couple of liberties and focus on a few different things. The first is, most of my comments are going to be based upon pancreatic adenocarcinoma, because that's probably the biggest deal within pancreas cancer. It's the big killer and the one that, I suppose, the disease entity that we as surgeons see most of. But a lot of the comments are probably reasonably transferable across the board in relation to pancreatic disease. But adenocarcinoma is really what I'm talking about today. Shari will probably agree with me in this, that having a surgeon speak about medical and radiation oncology is something like having a fox in the hen house. We are slightly different types of people. I do not administer or prescribe chemotherapy. I'm not responsible for the delivery of radiation therapy. I have a huge amount of faith in it and respect for it, but it's not what I do. But I will try to be as reasonable and balanced in my comments on it. But I am a surgeon, and as most of you know, surgeons are awesome. And there are lots of reasons why we think we are awesome, most of them wildly unfounded. But when it comes to the management of solid organ malignancy, our confidence is reasonably well based upon the fact that, with very few exceptions, the fact still remains that the single best opportunity for long-term disease control, and I'm reluctant to use the term cure, particularly in the field of pancreatic adenocarcinoma, because in truth we rarely achieve a cure, but what we can do is control disease very much more effectively now than we used to. But when it comes to controlling disease for solid organs, complete surgical removal of the primary tumour remains the best option. Now, with luck and with what you've just heard from Dr. Butler, that's going to change, but it's not going to change anytime soon. And as things stand, surgery remains one of the central tenets of oncologic management, and so we're awesome. I have no disclosures as yet because I'm still relatively early in my career, but I'm open to offers. And at the end, I will touch on something that is pretty close to our hearts in Toronto General with a program we have called Perioperative Interactive Education. And it's one of the things that we should be doing an awful lot better, and that is educating patients and their support networks about what they can anticipate in terms of their treatment and management and outcomes, and what they're going to face when they do submit themselves to care under surgeons. So, a few basic concepts to clarify first. What is adjuvant therapy? Well, I think it's important to point out, I think as Dr. Butler has demonstrated, that cancer is a systemic disease, and by the time you come or by the time someone is referred to a surgeon for management of their malignant disease, that tumour is not isolated to the one organ that has been identified as the problem. For a very long time, that tumour has been growing, and from the moment it starts to grow, it has developed the ability to escape immune modulation and control, and has spread to different parts of the body. Whether those individual tiny pieces of tumour have the capacity ultimately to become further tumours and create difficulty in the liver and the lungs or what have you, nobody can tell at an early stage. But to think of cancer as purely something isolated to, in the context of pancreas cancer, as just the pancreas is an error. What we do as surgeons is not a systemic therapy. We deal with a problem in a specific area, and we deal with it locally. What we do is we remove it. It's not subtle. The Whipple operation was described not quite 100 years ago yet, and it's a pretty big operation. And it is not an elegant manipulation of molecules. It is not a subtle identification of something really, really clever within a cell. It's pretty blunt. And I suppose surgeons are pretty blunt people, and what we do affects that one thing in that one place, not the rest of the body. So something else is needed to deal with those tiny fragments of tumour that may have escaped, and probably have escaped. And indeed, there are other things we can do that might help us when we're trying to deal with the local problem. And all of these things, anything that is added to what we do, is considered adjuvant therapy. Typically, it's considered chemotherapy, so drugs, chemicals of a sort that are administered to the body and affect the entire body. And the idea is, no matter what type of chemical it is, the idea is that malignant cells, or rapidly developing cells, will be affected specifically by this type of chemical. But it won't be just the tumour cells that are affected. There's other parts of your body that have similar characteristics to tumour cells in that they replace themselves regularly, and as a result those are the things that can be affected by chemotherapy and can give rise to the side effects that everyone has heard about and you hear terrible stories of. And in the context of pancreatic cancer, the common drug names that you will hear are gemcitabine, which has been the backbone of adjuvant therapy in pancreas cancer for 20 years now, 5-fluorouracil, something similar, an older chemotherapeutic agent, but one that's very effective and used across a variety of different gastrointestinal tract malignancies. Platinum-based chemotherapies, and then some of the newer combination chemotherapies like FOLFIRINOX, which is a combination of several drugs, quite effective but quite toxic, and more recently again some newer agents such as Abraxane. Immunotherapy you've heard far more elegantly about just now than I could even manage to pretend I knew anything about, so I'll move along quickly. And radiation therapy, which is like surgery, is a local therapy. It's aimed at the location of the tumour, and the idea is that it's either going to affect the tumour before you try to remove it and shrink it, or indeed reduce the size somewhat so that you can you can more safely remove the tumour without leaving any of it behind. It's somewhat contentious in pancreas cancer because maybe 15 years ago some very good evidence demonstrated that the addition of radiation therapy to chemotherapy following surgery for patients with pancreas cancer did not help them, and in actual fact gave rise to significant problems. And certainly in Europe and here in Canada, the standard of care is not to administer radiation therapy following surgery, although in the US, because of some probably not such good quality evidence that was generated in the US, somewhat biased obviously, some centres will recommend adjuvant radiation therapy, but here in Toronto we do not routinely. Neoadjuvant therapy then is something that we do prior to operating. It is a concept that over the last 20 years has gained a lot of traction, particularly in other gastrointestinal tract malignancies, esophagus, stomach, colon and rectum specifically. And the idea is that some treatment prior to planned surgery on what might be considered a very large tumour, or a tumour that's located close to a major blood vessel or some other major structure that could not safely be removed, treating it beforehand might either shrink it down or mean that you don't have to be quite as aggressive at the time of the surgery and leave the threatened structures intact without threatening the patient's life by performing the operation. Whether that's actually true or not is hard to say, but certainly there's been excellent evidence in some other tumour locations. Another, I suppose, concept within the notion of neoadjuvant therapy is that you might actually make the leading edge of the tumour, or the tissue at the edges of the tumour, the interface between normal and abnormal tissue. It might now make that part of the tissue that's about to be removed safer. In other words, that you could, by getting perhaps a little bit closer to the tumour than you would have liked to do with your surgery from the outset, you're not actually leaving anything dangerous behind. So again, enhancing your ability at the time of an operation to remove all of the disease, or at least all of the disease you can see and feel at the time. And there's been very promising data in other in other cancers that neoadjuvant works, and it is the standard of care for esophagus, rectal cancer, and for certain types of gastric cancer now. Not quite there yet with pancreas cancer, but we'll talk about that momentarily. One of the most encouraging things about neoadjuvant therapy is that, particularly in relation to esophageal cancer and gastric cancer and rectal cancer, it has been found that those people who were treated with combinations of chemotherapy or combinations of chemotherapy and radiation therapy prior to their surgery not only had successful surgery with removal of all of their disease more frequently than those who did not get the treatment beforehand, but that they were surviving longer, or that it was taking longer for the disease to come back, or that a cure was achieved more regularly than in cases who did not have neoadjuvant therapy. And so it holds potentially lots of promise if you get the right combination of things in advance. It's relatively new in the pancreatic cancer literature, but I can tell you anecdotally, albeit without a huge amount of evidence just yet, that in some of the major centres in North America and in Europe, including Mayo Clinic, some in Cambridge, and in MD Anderson in Texas, that preoperative chemoradiotherapy for adenocarcinoma of the pancreas is becoming standard of care, and we may well be following suit in the not too distant future. And as I said, it can be a combination of of a variety of different modalities, and is frequently both chemo and radiation therapy. Does it make a difference? Well, only yesterday, one of my colleagues recently moved from Toronto General to the Juravinsky Cancer Centre in Hamilton, published the experience out of Toronto General over the last 20 years in relation to the management of pancreatic adenocarcinoma at our centre, looking at the period of the 1990s and then to the first decade of this century. And the good news is that patients treated in our centre, their median survival has doubled in those two time periods. And the real difference is, okay, we're doing a lot more of the surgery, which is important, and we'll talk about why that is in a few minutes. But the big difference is that more patients are getting adjuvant chemotherapy. So there's an enormous benefit to being treated after the fact if you have an effective agent. And historically, the agents weren't terribly good for pancreatic cancer. But in truth, the biggest difference in pancreatic cancer management over the last 50 years has been that alone, the addition of adjuvant therapy. And that has done probably more in the last 50 years than anything other than us doing the operation better and more safely. The data for neoadjuvant chemoradiotherapy in pancreas cancer is still somewhat anecdotal. They're single centre based. They haven't been subjected yet to large-scale randomised trials, but the responses people are seeing are very impressive, and I think it won't be long before we have some better, what we would call highest level evidence to back this up. And I know my feeling on it is that patients I treat in the future, I would like to have referred, certainly to be considered for chemoradiation and chemotherapy before their surgery. And I think many of my generation of staff will agree and follow suit. Do we convert many patients from unresectable to the resectable category? That's hard to say. What I can tell you is that in Toronto General, we'll talk about it a little bit further later on in relation to advancing the boundaries of what we're doing surgically, but we have a group of patients in a sort of the preliminary part of a trial who under normal circumstances are not considered candidates for surgery. Their tumour is either too big or related to a major blood vessel or two blood vessels, vein and artery, and in most centres in the world they would not be considered for surgery. And we've treated over 40 patients now with a combination of either chemotherapy prior to surgery followed by surgery and chemotherapy thereafter, or chemotherapy and radiation prior to surgery and more therapy thereafter. And we've seen in about, of the 40 or so who came to surgery, about half of them, their stage of, or at least the level of disease had changed. So in all of the patients we reckoned were going to require a reconstruction of an artery and vein at the time of their surgery, actually only half of them did require that. Their tumour had shrunk. What is that going to mean for them long term? We don't know yet, because this has only been over the last couple of years, and it's going to take some time before we see how these people do long term. And whether or not their long-term survival is affected by the fact that they were treated prior to their surgery and then had surgery without it being a more invasive surgery. But it's certainly encouraging that preoperative therapy can shrink tumours to this extent. But as I said, poor data so far. And there's no question but that the addition of chemotherapy in a situation where we cannot remove a tumour is of enormous benefit. Typically it's been gemcitabine-based chemotherapy, and again that has significant impact on slowing down the progression of the disease and the length of life people can expect after the time of their diagnosis. But like anything, there's a downside, and as I mentioned at the start, chemotherapy has side effects, and the side effects can be pretty nasty. The gemcitabine-based regimens for chemotherapy are pretty well tolerated. Usually, when a drug is very well tolerated in this field, it means that it's not enormously active, or else it's a very special type of drug. And there aren't that many very special type of drugs that we use on a routine basis just yet that are out with the remit of a clinical trial. But so far, as we know it to date, gemcitabine is probably the most well tolerated of the chemotherapy drugs. But the newer ones, the ones that have been showing efficacy in the neoadjuvant setting, tend to be quite toxic. They are associated with significant immunosuppression, so they reduce your own ability to fight off infection, and if that happens to a bad level, it means that therapy has to be stopped. It can have significant impact upon the lining of the gastrointestinal tract. People can have really bad diarrhea, bleeding consequences, and again, that's something that would mean the therapy has to be stopped. And with the platinum-based, some of the platinum-based chemotherapy agents, they can have significant impact on sensory nerves in the hands and the feet with what can be pretty nasty consequences. So yes, chemotherapy is useful. Yes, it can have an enormous impact, but there can be a cost, like with everything. Unfortunately, the more active regimens require that you be pretty healthy, that you cannot have any other major comorbidities in your lungs or in your heart, and you need to be pretty fit to have them, which is somewhat ironic when you're trying to suggest to someone with a pancreas cancer that they need to be pretty fit. But those who are younger and fitter will tolerate them and hopefully get the best benefit from them. But not everybody will be able to finish their course. And that kind of skews the picture for us somewhat, because everyone we want to treat can't necessarily get all the treatment. And we can't make very clear statements on basis of it. So, what's changed in surgery? Well, some would say very little, some would say huge amounts, and I think it depends on your perspective. There's a few things that I'll concentrate on over the next couple of minutes to explain what has happened in relation to pancreas cancer surgery over the last 10 to 15 years. But broadly speaking, it comes down to the fact that the surgeons who are doing it are doing more of it, and as a result are doing it better. That we do the surgery because we're doing it better, patients have better outcomes. They have fewer complications. There's less in the way of leakage from the reconnections on the inside after the Whipple operation, less leakage from the pancreas that's been divided and cut, and fewer complications with infection in the time that they're being treated and patients are being treated in the hospital thereafter. So broadly speaking, we as surgeons, as institutions, are getting better at dealing with these very complex patients. And some of us are doing our best to advance the boundaries of minimally invasive surgery, something close to my heart that I'll talk about shortly. And finally, I'll talk about what I've been involved with some of my colleagues in Toronto General in terms of really pushing the boundaries of what is considered possible in relation to this type of surgery. The doing it more, doing it better notion has been around for a long time, and up until about 10 years ago we didn't have very good evidence to suggest that if you did more of this type of surgery you probably did it better than somebody who did it once or twice a year. There is now absolutely no doubt whatsoever that high volume will translate into better outcomes for patients, and as a result the practice structure and referral structure around the world and specifically within Ontario is changing, and that's a very good thing. More is definitely better. If you do 50 Whipples a year, you are going to do it better. Your patients will do better than someone who does it 5 times a year. That doesn't seem like rocket surgery, as a friend of mine puts it, but the simple fact of the matter is, if I do this every day of the week, I'm going to be better than a guy who does it once a month, and that's the truth. We now have lots and lots and lots of data to back that up. I don't care how good Professor so-and-so is or was 20 years ago at doing the Whipple when he trained. If he hasn't done it in the last 5 years, he shouldn't be doing it now. High volume centres on foot of increased activity are better than low volume centres. So it's not just about the guy who's holding the scalpel and the forceps and putting in the stitches, it's about everything else. So if a hospital sees a Whipple patient once a year, they're not really going to be able to read the signs when something's going wrong. And something will go wrong. It's a complicated operation, and the complication rate is a minimum of 30%, even in the best centres in the world. And one of the best centres in the world is directly opposite Princess Margaret on University Avenue. These are complex patients with complex medical issues, so complications occur. And if your hospital only sees a patient once a year, you won't recognise the warning signs. However, if you see 100, 120 a year, you will see the blood test that tells you, oh, something's about to go wrong here, we need to intervene now and deal with it. The ability of an institution to rescue a patient in either about to embark upon a dire course in their clinical period, or who has already had a major complication occur, is based almost exclusively upon the volume of work that they do. So if you or if someone you know is embarking upon complex surgery of any description, but specifically in relation to cancer, they should be going to a place that does a lot of it, and that's very, very important. Multidisciplinary teams get better results. This is more of the same. In big institutions, you have medical oncologists, radiation oncologists, surgeons who do lots of this type of surgery. You have nurses who see lots of these patients all day, every day. Physiotherapists who deal with patients who are getting over Whipple. Dietitians who deal with patients who are getting over Whipple, etc., etc., etc. And they usually have access to the community services that smaller institutions do not have. So when you have all of the facilities at your fingertips that you need to run a service like this, you do it better. And fortunately, within the structures within Toronto, or within Ontario generally, many of the hospitals do have this. And I'm particularly spoiled in Toronto General in that we have a remarkable multidisciplinary team from the moment patients are diagnosed through until they're discharged home, hopefully very well. And finally, on foot of all of the evidence that backs up the volume outcome argument has come the regionalisation of pancreatic cancer care in Ontario. There, I see on the booklet today that it lists 9 centres. There are now 10. There was another surgeon appointed up in the Thunder Bay region, so they are now doing, there have to be at least 2 surgeons doing a minimum of 15 cases a year to meet the volume criteria. So there are 10 centres within Ontario caring for patients with pancreatic cancer, and rough count of the leaflet says something like 25 across the country, and that's pretty good as long as the volumes are being met. And I think the way, given the publicly funded service like you have here in Canada, the way it's being policed, it's very encouraging to suggest that pancreatic cancer care from the clinical perspective should be delivered at a very high level all across certainly the province, and if not the rest of the country. Minimally invasive surgery is my thing. I've spent a lot of time, a lot of my family's time and money getting trained to be able to do this kind of surgery laparoscopically, and that's an unusual phenomenon. I lack insight on a spectacular level, according to my wife. But it's relatively new. Minimally invasive surgery has been around for more than 30 years, and many of you will have had friends or may have had surgery yourself. You had the keyhole operation for the gallbladder or the hernia or whatever it was, and it's gaining traction across specialties the world over. It has been very slow to be adopted in liver and pancreas surgery because liver and pancreas surgery at the best of times is technically challenging. And when you try to do it at the end of what are effectively chopsticks with a occasionally fairly poor quality camera looking at things in 2D while trying to manipulate complex things in 3D, it can become quite difficult. So it's only been in the last decade or so that people have started to adopt minimally invasive approaches in the field of pancreas cancer and liver and pancreas disease generally. It's not just about not making a big hole in somebody, but the actual fact that you don't make a big hole in somebody to do an operation has an enormous, enormous impact. The impact upon the patient's immune system is much less, so their ability to fight off infection and heal themselves in the immediate perioperative period is greater. There is lots of evidence from basic science up to major clinical studies to demonstrate this now. It has a much lesser impact upon their cardiovascular and their renal or kidney system during the time of their hospitalization, all of which means that their recovery is faster. They have less pain after the surgery, so they're easier, or they're readily able to get up and out of bed and walk around and avoid the risks of clots in the veins in the legs that can go to the lungs. And all of those complications are much reduced in the group of patients across the board who have minimally invasive surgery. Long term, they are much less likely to get a hernia from their incision because the incision is much smaller. The hernia rate from a laparoscopic port site is less than 0.5%, and that's a wild overestimate as it is. But for a major laparotomy, so the big long incision in the midline, the lifetime herniation rate is greater than 30%. So there's an enormous benefit from that alone, albeit in pancreas cancer that can be a difficult thing to demonstrate a benefit on because you need a lot of people living a very long time to demonstrate that benefit. And things like adhesions that can cause bowel obstructions and things like that do not happen after laparoscopic surgery in anything like the same frequency as they do in open surgery. I'm a zealot. I believe very, very profoundly in the benefit of minimally invasive surgery, but to try and demonstrate it in this subspecialty is difficult. What's important to prove is that it's every bit as good as open surgery when it comes to the cancer outcomes. And fortunately, there is now a wealth of data to back this up. Unfortunately, very little of that is in relation to pancreas cancer because there are very few people doing pancreas cancer surgery laparoscopically. Last month, finally, probably the leading exponent in the world of laparoscopic Whipple, a guy called Michael Kendrick at the Mayo Clinic in Minnesota, published his experience, and he has shown that not only is it every bit as safe from an oncologic perspective to do a Whipple laparoscopically, it actually shows probably an oncologic benefit in that patients with pancreas cancer who have had their pancreas removed or their cancer removed laparoscopically show a much longer time to progression. So their disease doesn't come back as quickly as they do in the open group. And it's the first time this has been demonstrated in solid organ cancer. Granted, it's from one centre and it's from one person who's remarkably skilled. But it's of enormous encouragement to people like me and to my generation of surgeons coming through who will hopefully do this more and more, because the benefits to the patient in the short term are huge. Just saying that, well, there's no benefit long term is no good. If it's every bit as good as open surgery, then I feel, as a profession, should be aiming to provide the patients with the short-term benefits of shorter hospital stays, fewer infectious complications, less pain, faster ambulation, all the things that laparoscopic surgery is famous for. But it's hard to do. Believe me, it takes a while. But I think it's worth persisting with, and it is becoming more widely available now in Toronto. My colleague, Dr. Jay Raman, in St. Joseph's Health Centre down in the Queensway, does Whipple laparoscopically. He commenced on it 3 years ago now, when I worked as a fellow with him in minimally invasive surgery, and his experience has been building all the time. It's unlikely to be introduced in Toronto General in the near future. Robotic surgery may come in ahead of it, but with Sean Cleary and Ian McGilvery, it is on the horizon, and it's something that I think patients and their support network should be asking about and advocating for, because now that we know that it's every bit as safe to do it laparoscopically as it is to do open, we should be putting the pressure on my colleagues and me to develop the skill set to be able to provide this service. But of course, I'm biased. Robotic surgery. You can't have a discussion about surgery now without talking about the robot. It is undeniably very cool. You have a surgeon sitting in the corner at a console. You have the machine over the patient at the table with the instruments going in, and you can have a second surgeon either observing and learning or assisting. On the face of it, a fantastic notion, but all is not as it seems. I think I'm not an enormous believer. Certainly, if you go south of the Canadian border, there's an awful lot of advertising for robotic surgery. It's a big selling point in a competitive healthcare market, and it has been driven by one company, Intuitive Surgical. They are the only players in the global game, and a natural monopoly is not a good thing. I won't dwell too much on it, other than to say that yes, robotic surgery does have something to offer, but I think if you have an advanced laparoscopic skill set, you don't need a robot, and all it adds then is a huge amount of cost to what you're doing, but it's growing. This is from an article from the Wall Street Journal from just last year that shows that it's growing exponentially within the US. There are robots in downtown Toronto. There are robots all across Canada. They're not being used heavily because as yet there are no really convincing data to suggest that the robot is a really good thing to use. And in actual fact, the first class action suit for complications sustained at the time of robotic surgery is currently recruiting in the US. So Intuitive have had a good 15 years. They may be running into a little bit of a sticky time. I don't want to poo-poo it completely, because it does allow people to perform minimally invasive surgery who perhaps do not have the advanced skill set to do it laparoscopically, but it is not the panacea, it is not the great white hope. It's a long way from that yet. Having said that, 15 years from now it may well be the standard of care, but it needs to get an awful lot better than it currently is. There's very little data in pancreatic surgery, certainly nothing of a very good quality, randomised or multi-centre, and I would counsel great caution to anybody who's thinking of embarking upon having their surgery performed by a robotic pancreatic surgeon, because as yet there's very little to suggest that that's a better way of doing it, but it's certainly a very good way of generating revenue for a hospital. Now, in terms of pushing boundaries, where are we? Well, in Toronto, we're very well served by having probably the most aggressive surgical unit in North America right now. Typically, patients who have tumours that have grown around the major arteries, and there are two, are the major vein, the portal vein, in the region of the pancreas, are not considered candidates for surgery. And that in the last few years has changed slightly. We don't know if it's a good idea to remove somebody's celiac artery or superior mesenteric artery and reconstruct it at the time of pancreas cancer surgery, because it's never been tried before. It's never been demonstrated that it's, first of all, safe. When it was first tried in Memorial Sloan Kettering in New York in the 1980s, the mortality rate was spectacularly high and unacceptable, and the morbidity rate was almost 100%. So people had, if they survived the surgery, they had massive complications, and that was just unacceptable. Now, things have changed. What has changed? Well, over the last 15 years, globally, particularly on foot of people's involvement with liver transplantation, surgeons got better at dealing with the major blood vessels, particularly liver and pancreas surgeons. And we found that, on the basis of lots of very good population-based evidence now, that if the portal vein is wrapped around by tumour, taking the portal vein out and reconstructing it isn't technically that challenging a thing to do if you're a transplant trained surgeon, which a lot of us would be now. And not only that, but from a cancer point of view, patients do every bit as well as those who do not need to have their vein removed. So if you think that the vein is involved by the tumour, rather than trying to peel the tumour away from the vein and probably leave tumour behind, you should just take the vein out and reconstruct it. Patients will do well, and long term, from a cancer perspective, they'll do every bit as well as if they had a smaller tumour. We demonstrated that ourselves in Toronto General with a paper a few years ago. And not only did we demonstrate that it was safe to do, but we also demonstrated that it was safe to plan to do it. And if you had any concern at all prior to the surgery, that on the basis of the scans or what have you, that the tumour might involve the vein, you should prepare ab initio to take that vein out and reconstruct it, rather than say, well, I'll try and remove it off the vein in the middle of the operation, but if I tear the vein, I'll fix it. That's not a good way to go. Plan to do the bigger operation and the patient does better. The artery is the question that we're trying to answer now over the next couple of years, and the trial that I mentioned where we're treating patients prior to surgery, where almost half of them have had their tumour shrink away from the artery. It's called the RCAP trial. It hasn't quite started yet. It's in a variety of iterations in terms of trying to decide what's the best combination of drugs and radiation to give prior to the surgery, but my colleague and mentor Ian McGilvery is leading it. And what we have demonstrated with our first 40-something patients is that when we need to remove the celiac artery, or the artery going to the liver, or the artery going to the intestine, the superior mesenteric artery, we can do it safely. Now, what that means is that, yes, patients will have some complications, but they won't die as a result. And historically, if you tried to do this, the vast majority of patients didn't make it out of the hospital, which made it an unacceptable thing to do. Now we know that we can get patients through the surgery safely, principally because we do a lot of this kind of surgery with transplant, and particularly in Toronto General with live donor transplantation, which is even more complex again. So what we need to know now is whether or not it makes sense from a cancer perspective. We hope it does. If it does, it will rapidly expand the number of patients who become candidates for surgery. But as yet, we don't have the data, and it's going to take us a couple of years to accumulate it. But what it also does is it offers an opportunity for someone who in the next year or two is told in whatever part of the country that they cannot have their tumour removed because it's wrapped around the artery. Then you know that there is an institution somewhere that can at least offer you the opportunity of being recruited to the trial, potentially having your surgery and seeing what happens. Because as I said at the start, the single best option for long-term control of the disease is surgical removal of the tumour. And if you cannot remove the tumour, the long-term survival is miserable. It remains in the 6 to 9 month category, and there's nothing that has been done to improve that just yet. It's also important to point out that Ian McGilvery isn't in every hospital in the country, and there's a small number of people who will have the skill set and the training and the regular exposure to that level of complexity of surgery to be able to do it, and it should only be in places like Toronto General and high volume, ultra high volume, ultra specialised cancer centres that provide this. So if somebody's saying, well sure, I'll have a go at it for you, that's not the person to have the operation with. So finally, the issue on patient education. I think we historically have done a very bad job of preparing people for what they're about to face. And it's kind of difficult to tell someone what they're about to face when they're facing into a Whipple, because it's a big deal. And if we explained in living colour to everybody who was due to have one, I'd say we would lose an enormous number of volunteers very, very quickly. And then there's their opportunity for long-term control lost. Plus, there are reasons. Surgeons are surgeons. We like to operate. We don't like to do other things. So if I have an opportunity to do an operation, I'll do an operation. And obviously then the information I'm going to give someone is a little bit biased. If all you have is a hammer, everything you see is a nail. We need very much to do a better job of preparing patients and their support groups, their mum, dad, significant other, their kids, for what they're about to go through. Because it's not just about the patient on the given day. There's a huge amount of psychological fallout and a huge effort that's put in by the loved ones at home in terms of getting people through this surgery. And as part of the perioperative interactive education program based at Toronto General, and with my colleagues at the Toronto Video Atlas of Transplant, Liver and Pancreas Surgery, we've developed a patient education video which is freely available online. I think there's a link on the PanCan website. And I would encourage anyone who's facing into this or knows someone who is facing into this to look it up. the images you're looking at are based upon 3D reconstructions of an actual patient's anatomy and the tumor that they had. It's not something just made up or taken off the web, which is part of the Surgical Atlas, which is a very high-end teaching tool. But from the perspective of patient education, it runs through, as you can see, the various different issues: the anatomy of the pancreas and the anatomy of the individual tumor, what will happen at the time of the surgery, the various treatments that are available to patients and how those might be administered, what they might anticipate from them in relation to side effects and complications, what it is exactly we do on the day of the operation, what's removed, because oftentimes people will come back to us a year after their Whipple going, so my gallbladder, am I going to have that out? I said, well, actually that's been in a bucket in the laboratory for about a year and a half now. And it will explain the various subtleties of what happens then in the few days after the fact. And there are a lot of things. When a patient goes to sleep before a Whipple operation, they wake up with tubes coming out of parts of them that they never expected to have tubes in, unless they have a very entertaining weekend lifestyle. And it takes a long time over the ensuing week for those tubes to come out, for it all to start to make sense to somebody about what's happening to them. And I think initiatives like this that our colleagues have demonstrated or have developed are very, very valuable. And the feedback we've received from those patients who've gone through the system very recently, who had the opportunity to use the education video, has actually been very encouraging. And I think as time goes by, we'll get better at it. But this is something that's readily, freely available right now, and we would like to see more people use. So what's the bottom line? Facing into dealing with pancreas cancer is daunting. The numbers are bad. The information out there is usually pretty terrible. The internet's a wonderful thing, but there's an enormous amount of awful rubbish out there, completely devoid of context. And it's very important who you choose to get your information from. Choose people you trust. If it's your family doctor, your medical oncologist, your radiation oncologist, the local shaman, whatever, if it's somebody you trust, listen to them. But be careful. Remember that everybody's got an agenda, everybody's got the hammer with which they hit their particular nail, and everybody as a result is somewhat biased. The decision at the end of the day will be yours, or whoever it is who's facing the surgery, and it's very easy for us to be quite paternalistic about these kind of things, but at the end of the day, the decision is the patient's. So please inform yourself carefully. The best outcomes for pancreas cancer are achieved in high volume centres. There's no question about that. That's not opinion, that's fact. Not every hospital is the same, and as I said, the high volume places do it best. So be sure that you're happy with where it is that you're going. And there are certain ineffable things that we can't legislate for that will mean that people want to stay in their local hospital to have their surgery done, and that's fine if they're happy with that, as long as it's safe to have it done there. And the reason it would be safe is that they're doing lots of it. A combination of therapies, surgery, chemotherapy, either before, but certainly after, and maybe radiation therapy as a part of the mix prior to it all, certainly has a huge role to play and is of enormous benefit. As I said, in the last 20 years, the single thing that has got, the single biggest change to therapy in our own centre, which is one of the best in the world, has been that more patients get adjuvant chemotherapy, and as a result, people are living longer. And finally, best of luck to those of you who have to face this. You're fortunate in Toronto, certainly, and I think Ontario generally, that there is a pretty broad network of very highly trained people who are more than happy and only ready and waiting to help you with your struggle. Thank you.